Hello, and thank you very much to the conference organizers, the chair, the session, for allowing me the opportunity to present on the journey of wound care within the region. I'm Professor Mohammed Baguneid. I'm a vascular surgeon in Abu Dhabi, and the focus of what I'll be talking about today is wound care in diabetic foot ulcer care predominantly. So the perspective I'm going to give really covers a period of time that I've spent within Abu Dhabi, although not continuous in that time frame from 2013 till now. But before we go on to really talk about this journey, it's probably worth just recapping the reasons and the rationale why wounds fail to heal. Most people assume that the rationale is because of patient physical attributes, such as whether there's infection, ischemia, whether there's issues related to immunosuppression, trauma, pressure areas, for example. But it's much more than that, and including the concepts of health literacy for the patient side, socioeconomic factors related to the patient. But the thing that most people don't put emphasis as much as maybe they should are the areas related to the health professional and the health system that the patients try to encounter. So health professionals themselves, some have the skill and knowledge, some may not be such familiar with diabetic foot ulcers or wound care management. There may be an area which is outside their interest specifically, and the health system itself may not be easily accessible to the patients, maybe through insurance problems, or maybe just the resources isn't available or the manpower that is required to heal that patient's wound and ulcer aren't present. So there are many factors that all together bundle in which relate to why wounds fail to heal. So then the question really comes then, well, what's required for success? When I came to Abu Dhabi in the first instance, I would say patient volumes, they were no different really to what we have now. The population may have certainly increased, but there was no shortage on patients who have diabetic foot ulcers. In fact, if you look at the data now, something like 73 million people within the MENA region will have diabetes. And if you look at the data that assumes around 34% may have a lifetime risk of ulceration, that comes to about 24 million. And half of these may get an ulcer that becomes infected, half those with ulcers. It may develop an infection. And sadly, 20% of those in moderate to severe ulceration may require an amputation. And our goal is to prevent amputation. And most patients who then go on to having an amputation had failed the system, or the system has failed them, because most amputations are avoidable. So there's no doubt that the patient volumes, they're not an issue now, they weren't an issue before. And so then there comes the question really is, well, what's the difference in terms of staff resources? And when I look back for the 10 years or so, it's not staff resources within one particular team. It's this concept of the extended multidisciplinary team that helps get the outcomes that we're looking for. So whether it's endocrinologists, podiatrists, vascular surgeons, wound care nurses, there are many, many other members of the team that will help a patient with a diabetic foot ulcer, and in fact with wounds in general, to be able to improve. Infectious disease teams, vascular interventional radiologists for those who have arterial ischemia as well, physiotherapists, general surgeons who predominantly become the admitting surgical team in many hospitals that don't have a dedicated diabetic foot team, orthopedics who are required for those patients with Charcot's or osteomyelitis, and plastic surgeons for all those reconstructions as well. So you can see that this multidisciplinary team are very important, particularly for those complex wounds. 10 years ago, I certainly remember we had a few podiatrists within the whole of the United Arab Emirates who were serving that population, and vascular surgical team members were very few as well. And I think one thing that certainly has changed over this time is that this recognition of the importance of all these members of the team who were lacking and not available previously. We're still not at those numbers that are required, and wound care teams which are trained for this area not as many maybe as required for the huge volume of work, but nonetheless significantly better and coordinated as an extended team than they were over those years ago. But recruitment and retention is clearly very important. And this idea of networking between facilities, team members in different facilities, and trying not to work in silos. It's quite clear that even now, where networking between facilities is better than it used to be, there are still areas where patients access where there's a very limited number of staff to serve that population. So the facilities, in other words, the hospital, the healthcare clinics, the equipment that's often required, this idea of working as a joint care team, working across the region, not just within the government healthcare system, but within the private networks. And more importantly, nowadays, I would even say trying to work between the private healthcare systems and the governmental healthcare systems, which becomes an issue depending on people's insurance policies of where they can get access. And this is something that we are all aware of, and I would say may have improved somewhat from before, but still poses an issue for patients' access. For example, maybe some can get treated as an emergency in one healthcare system within the region, and their outpatient assessments will be managed in another area because their insurance policy doesn't cover them for the first hospital they attended on an elective basis. So they attended the hospital first as an emergency, they were covered, and then they go to try to get in there as an elective. Unfortunately, they're not covered. So these are issues which we certainly are aware of. And I'm just doing a Google Maps search and using the word hospital, and you'll see just the number of facilities which are within the Abu Dhabi region. Patients access one or another throughout their journey for that, for their wound care management. And there are some issues related to that, but some of that has now also improved significantly with the joint up electronic patient record systems that have been instigated within this region. That's helped us all identify where patients are actually being seen and seeing their previous records. But the pathways between these facilities, I would say, is still quite weak. Patients' access, as we mentioned, is quite difficult to some facilities where maybe the multidisciplinary team is more built up. And although there are many local guidelines within various different parts of the healthcare sector, I would say that the missing part is this joint up common guideline or acceptance of a common guideline within the region as a whole, within the different sectors, would be very helpful if it was present. Knowledge and raising awareness is very important, key to success in these situations. And it's not just for the staff. I'm talking, of course, with patients, raising their awareness and ensuring that they have adequate knowledge. And even just doing a Google search on wound care sort of conferences within Abu Dhabi, you can see that not surprisingly, this one is showing quite high on the number of searches, but there are many others. And this is something that we'd say has increased over time, not only conferences, but lots of educational activities. And there are many which aren't even necessarily listed. As we all know, the industry-sponsored wound care educational events are becoming much, much more useful for clinicians in general to be attending for further knowledge. So I think knowledge and awareness amongst the healthcare professionals is greater, but it's not uniform. And I think there's still significant pockets of knowledge gaps where patients may access that healthcare system. So we talked a little bit about guidelines just then, but protocols and pathways are being developed, and the integrated linkage between the different facilities are starting to build up. Most healthcare systems within Abu Dhabi now have a network concept. Whilst there is a network concept, it doesn't necessarily mean that the pathway between them is clear for every underlying disease condition. And I would say for wound care and diabetic foot ulcers, I think there are still some issues related to where patients maybe with low risk should be entering and where those with the complicated ones should be entering as well. And I think these issues means that patients sometimes don't know where is the best area for them to be seen. And if we look at a guidelines that are present in any one of the healthcare facilities, the guidelines have to not address just one factor of that patient's management. And this idea of a more holistic sort of approach, considering the systemic factors, not ignoring the idea of diabetic control, the immunosuppression, underlying malignancy that might be present in this patient that's complicating their wound care. These should be also incorporated in some guidelines, not just those which are more to do with the local environment of the ulcer. Antimicrobial stewardship, a huge issue in the Middle East, and an area that's being addressed in sort of varying degrees of strictness between different facilities, but it's certainly an issue in terms of the proportion of patients who have multi-drug resistance. This is a nice sort of chart that basically gives you the idea of just the degree, and it's not just gram-positive resistance, it's gram-negative resistance. And I'd probably say that in the time that I've seen in the region, it hasn't gone down. The gram-positive resistance seems to be about the same, but I think we're seeing much more of these multi-drug resistant gram-negatives, and they cause their own issues. So what were the common issues in the emergency diabetic foot ulcer presentations that were seen, let's say, 10 years or so ago? Well, the advanced presentation of the patient's condition, that's pretty much still the same at the moment. We see patients here in far more advanced state with their diabetic foot infections when they attend as an emergency, and far more Charcot's joints and osteomyelitis than we would see, let's say, in Western Europe. 10 years ago, there were certainly more patients undergoing major amputations, and I'll discuss that a little bit more in a second, but patients were having delayed diagnoses, maybe inadequate assessments, particularly the vascular assessment, where it is very difficult to assess peripheral vascular disease in patients with diabetes, but where that facility of doing Dopplers or toe pressures were not available, often we would have inadequate assessments. The poor antibiotic stewardship, which was present certainly those many years ago, I feel there's have been addressed much more, but still a concern. But like I mentioned, it's become probably a greater concern because of the increasing prevalence of these multi-drug resistant organisms. We still have that lack of agreed guidelines that sort of network and mesh all the different healthcare facilities together. But I do think that most centers have their own guidelines, which probably do formulate from the international guidelines, particularly around diabetic foot ulcers. Fixed pathways, still an issue now as it was before, as I mentioned, but within any one different organization, the network might be a little bit more established than it certainly was 10 years ago. And MDT meetings for complex diabetic foot patients, I think this is an area that's still difficult to set up on a consistent, sustained way because of the probably difficulty of the recruitment retention of staff. In other words, staff remaining in sites long enough to have all the multidisciplinary team members to have an appropriate regular meetings. So I thought I'd just show this audit that we did. This is a number of years ago, and it was simply demonstrating how bringing together a multidisciplinary team does actually improve outcomes. And it was when the vascular service was set up in one of the government healthcare hospitals many years ago, and we looked at the data before that vascular network was set up to the same period of time, 10 months after the vascular network set up. And we looked at all the patients who have primary diagnosis ICD-9 codes that relate to atherosclerosis, diabetic foot infections, and all non-traumatic arterial problems with the lower limb. And we had 63 patients that were in the preceding 10 months before the vascular network was set up, and 80 patients subsequently in the 10 months after that. And what was striking to see was the significant difference in the major amputation rates prior to a vascular network being set up for patients with diabetic foot and peripheral vascular disease. 17.5% of the admissions, and these are true sort of emergency admissions we're talking about with diabetic foot and atherosclerosis, 17.5% of them, 11 out of 63, resulted in having a major amputation. In the period of time once the team were put together, not necessarily for a very long time, the rate had dropped down to 10%, and the mortality rate from 4.8% to 1.3%. Well, how was that done? It wasn't just because everybody was being revascularized. It was because there was a methodical approach to how to manage patients. There were certainly significantly more debridements, minor foot amputations, and endovascular treatments to revascularize patients, more so in the team when the team was set up together. And there wasn't a significant difference in length of stay between those two time periods. So doing all that effort and work to save people's limbs doesn't necessarily increase the length of stay. As we know, amputations have their own issues in terms of discharging from hospital. So really, to conclude, when I look at the 10-year period, I certainly see significant improvement, but areas that still need to be addressed, whether it's the patient access into services, or whether it's still retaining a good, strong multidisciplinary team in one network. These are issues that we need to be addressing, but there's no doubt that enthusiasm and a desire to improve patient outcomes are key to continuing this journey and achieving excellence in care. Thank you very much.